of the most difficult thing that staff nurses have to deal with is ethical dilemmas. I mean, once they've been here 6 months to a year and they've got the technology down pat, then you really get stuck with the why and the what am I doing to this person and what is this person experiencing. And you've got to be able to cope with that and live with that in order to stay at the bedside.
There's so many pros and cons, and even though you make a decision, it isn't necessarily the correct one.
I may be wrong sometimes in going ahead and giving aggressive therapy to someone and prolonging their life and making them suffer. In that case, maybe I am taking the family side above the patient's.
There are a lot of times patients in the ICU that we feel that way about. Then you're in a real gray area.
Even when you make the right decision on an issue, you might still face tragedy and loss and guilt. Nurses see a lot of tragedy and suffering. In some ways, I picture the hospital as an institution which kind of draws and concentrates suffering into one place, and nurses, therefore, are specialists in suffering. And they kind of sweep it up on the wards. And they come and talk with ethicists and say, what am I supposed to do with all this suffering? I think ethics offers clear thinking about these decisions, some perspective on their nature and their ancient history, some comfort, and clarity about choosing directions in the face of uncertainty.
The principle of beneficence encompasses the ideas that we ought to avoid harming patients and that we ought to do good for them.
And the necrotic area in the right forearm is better with less erythema. These pulses are full and found that we began with pressures of 20 over 4, 10 breaths per minute, and 35 to 55% O2.
TJ was born with severe birth defects. Even before she was born, her mother had decided to give her up for adoption, and so TJ is a ward of the state. TJ is profoundly retarded, and she'll probably never be able to see, hear, walk, or talk. She can't suck and vomits back her feedings, and the nurses have to decide how aggressive to be in feeding her. It's also very risky for the nurses to even hold TJ, because when she's taken out of the isolette, her temperature drops dangerously low.
What we're trying to do now is wean her from the isolette. And we've tried to do that several times, and it's just not working. She was out yesterday, and her temp went down this morning. After 24 hours, it went down to less than 35 rectally. So for her feeds for you, I put her back to SMA.
On the one hand, we want to say one thing is in the child's best interest, that is perhaps not treating her because of the possible pain or suffering. And on the other hand, we've got the concern about whether not treating her is wrong. And that's what there's some disagreement about. You have to get permission. Jana is TJ's primary nurse. Jean is another nurse caring for TJ. The nurses involved in this case have to figure out what it means to care compassionately for this child. What their obligation to do good for her actually entails in nursing practice.
As far as I'm concerned, it's feeding. Feeding is really an issue, and keeping her warm. If you don't do that, then she is going to die. And if she's going to die anyway, then let it be from something else, but not from lack of what I consider to be just basic nursing care.
I feel to some extent that if she is going to die, that we could allow her to die, even if it is by dropping her temperature or by the fact that she's not tolerating, and that if it's a course that's naturally going to occur, that she is going to die, that we're just prolonging that. We're extending her life.
I guess I'm torn between what is causing the most harm. Putting the tube down, giving her food, and having her vomit, or just not bothering with that whole process to begin with. Putting a tube down your nose is a painful procedure, and it's, to me, aggressive, and I didn't want to start doing that with her. And I don't feel that even if she does live very long, the quality of her life is going to be very good. And I just feel we should do comforting actions with her as far as holding her and trying to feed her, but not doing a lot of aggressive tests with her.
We don't know if she's going to live or not. That's the whole point. I feel comfortable when I know she's eating. When I feed her and she doesn't take it, my instinct is to put a tube down and make sure that she gets it one way or another. I don't feel that that's aggressive. Jeannie does. To me, it's just maintaining her. I just can't feed her and watch her either vomit it back or not take it and then know that she's dehydrating, because I feel that if she's dehydrating, she's going to die, and that I'm a part of that.
I don't think anybody has problems with the idea that she may or may not die. Nurses deal with dying patients, even little kiddies, all the time. I mean, that's nothing new to nurses. All we really want to do is not to do anything heroic. We're not talking about codes. We're not talking about anything that's dramatic. We're just talking about let's try and get her to keep her food down and let's keep her warm.
I don't think that you need to put someone through a lot of traumatic experiences if it's not going to do them any good.
So I don't feel that I'm aggressive at all, but listening to you, maybe I am.
But that's the nature of a dilemma, to be able to see both sides as justifiable.
But it's a horrible position to be in when you are the one that you see three sides, you see that all three would be correct, and yet now here you are, you're the one that has to put things in writing, and it's your care plan, and you're the one that's making recommendations.
Is there any possibility that a joint conference would be useful?
The nurses that presented this case have brought us some of their own ethical concerns about the case. This child raises issues that makes it difficult for us to know what will influence our decisions.
Should you push the feedings on the baby, even though they're probably not doing any good, just because it makes you feel that you're giving the baby some nutrition? And if the primary nurse determines that a certain route should be taken, other nurses may have difficulty dealing with that. In other words, if I feel that the baby should be hydrated and have adequate nutrition, other nurses might feel that it's an imposition to the baby to feed it or to risk aspiration.
In this case, what you're saying is, should we substitute comfort for whatever longevity this child's going to have? We take more risks with her life than we would with another child's life in the interests of more comfort in the short run, since we don't have much hope for her in the long run. Which is very much a nursing decision-making issue as opposed to a traditional medical decision-making issue. It's the here and now bedside decision-making. It's ongoing, and it has to be very private. What a doctor writes in the order book is rather exposed. But a nurse alone in a room with a patient has a lot more conscience to contend with.
The principle of beneficence, or doing good for the patient, sometimes conflicts with the principle of autonomy, that we ought to respect a patient's freedom to make choices.
For East 2, Case Bosford for East 2, please.
Okay, Arlie. Recently we've had some problems with close calls as far as falling goes, because you're not as steady on your feet as you used to be.
Remember I fell?
Yes. So I think that probably now's the time that we should consider maybe a restraint.
No, I don't want to be tied down.
Well, this isn't really to tie you down,
No.
Ollie. We're going to use this as sort of a reminder so that you don't get up without ringing your bell, so one of the nurses can come walk with you.
You know, I have the feeling that as long as I can do things for myself, I don't want to be bothering somebody else. I get my exercise by walking down the one corridor and then back, and then down the other corridor and back, upstairs here, and then down on the ground floor, too.
You'll still be able to do that, Olive, only you'll have company. Okay, Olive, this is the belt that we're going to use.
I don't want it.
I know you don't want it, but you realize how important it is. If you should fall, you're going to break something. And then it wouldn't be a matter of when you wanted to get up, you'd probably be in bed, and we don't want that to happen to you. But you'll always have your bell cord that you can ring for them.
I'm not going to be restrained.
Sharon has to weigh her obligation to respect Olive's freedom against her obligation to protect Olive.
It's always a hard decision to make, though. We'd rather have everybody just walking around and doing as they saw fit, because this is their home, and we like to maintain that as long as is absolutely possible, that they'll be comfortable here and to be able to come and go outside, visit family, friends, come back, go shopping, that type of thing. And it's a very difficult decision to make when a patient reaches the point where they just can't handle it anymore. And it is taking away a freedom from them that nobody really wants to take away.
Okay, Ollie. This is called a posy belt. Now you can wear it underneath your clothes if you like.
That'd be a good idea, then it wouldn't
show. Okay. We'll lift this up. There. See, we'll put this part in the front. See, you don't even know you've got it on.
Except I do.
You think you can live with that?
I guess so.
We'll try it?
I'll try.
Okay. So I'm going to go now.
Oh, are you going to leave this thing on me?
Yes, I'm going to leave it on now for a while. Okay, I'll be right there.
Another patient in the nursing home is physically fit, but mentally confused. The nurses have to decide how far they should go in protecting this patient, and how far they should go in protecting other patients from her noisiness and her wandering.
I have to make a decision this morning. Either we keep her, and she changes her mind and is willing to stay.
Which I don't think she's responsible enough to make that decision herself.
We keep her and medicate her and probably restrain her at the same time.
Take a woman that's fairly alert and make her
and who is physically in great shape and able to ambulate up and down the halls without a problem at all.
A lot of the nurses are opposed to medicating a person like that, but we probably would have no alternative.
It's a hard thing. It's something I do very reluctantly, even if the orders are there.
Physically restraining her doesn't even seem as bad as the chemical restraint,
where she has not got the opportunity to be away to fight it off.
Right, and it has so many
side effects. You can change a whole person's life.
No, I would prefer
their whole personality.
Yeah, but also the physical restraint is not going to keep her quiet, right? Which is a big problem with all the other patients on the floor.
You end up doing both.
Well, there isn't any.
There's no happy medium.
Any way to.
No. And she's frightened. She has nobody to turn to. It places the burden of responsibility directly on the nursing staff.
The principle of justice holds that we should treat people fairly.
I've now decided to go ahead and deliver the baby, try and save the mother. That will probably be done within the next 2 hours and 15 minutes. What's our bed situation thereafter?
Well, I'll call on the person who's on call, then I'll leave us 2 empty beds. If we have a light admission, we can probably absorb them. We can't really accommodate 2 more people tonight.
Thanks, Francis.
In a situation such as an ICU, where you have a limited number of beds and you have more patients than you have bed space, nurses are confronted with making a decision as to who gets a bed and who doesn't. And in that decision, they are essentially relying on the principle of justice. If you have already 10 patients and you're staffed for 10 patients, and you bring in another patient who's just as sick and perhaps even sicker than some of the ones who've been there for a while, how are you going to spread your resources? How is that patient going to be accommodated and get the same kind of quality of care?
Okay, what I called you about is Dr. Elliott's next patient. And right now, we do not have a bed.
Frances is the charge nurse of the intensive care unit. She and her staff have to decide with physicians which patients will be admitted to their unit, discharged from their unit, transferred from their unit. Nurses know an awful lot of things about those patients. All the things that a nurse knows about a particular patient can, and perhaps inevitably do, enter into the nurse's decisions about whether or not that patient should stay in the intensive care unit, or whether or not that patient should get one-to-one care. So the ethical question is, how do we choose fairly? Which of those factors should count?
I try and bring in reality. I look at prognoses. And again, that seems to be something that a nurse isn't supposed to do. But if you're here long enough, you know. Better to schedule the heart in bed 6 with the nurse all to herself, because the work you put into that is something that you're going to see some results from.
When there is a bed crunch, when the staffing comes tight and we can't get any extra nurses in, many times because there are viable patients who need the bed and someone who is not going to live out of the unit is in the bed right now. Many times, if there are no critical care beds in the hospital, there is more of a push to have those kinds of decisions made.
Vern's not answering.
Did I what? Measure from the gum. Measure from the gum.
It doesn't matter which side.
We've never had the President of the United States granted, but we've had like a congressman's son.
I'm sure it was because of the patient status that a lot of the cooperation was engendered at 6 o'clock in the morning.
The quality of this person's life is a real important factor. We have recognized a mindset that old people are not as valuable as young people. They've lived their, it's a whole bunch of ways of saying it, but it's saying, gee, he's had a good life, you know, why should we put him through all this? You put him through all this for the same reasons you put anybody through all this, is in order to live. And if you've got 5 years to live and that's what you want, you have a right to that.
We send them out after they've had the open heart surgery, they've stabilized, but they're still not strong, really. They still need a lot of attention. There's a disagreement with the attending service about whether or not the patient goes out. For example, I think the patient should stay in. They go out, and then that baby, say, has a respiratory arrest in the middle of the night, has to be intubated and brought back up again. I get mad. If the baby isn't ready to go out, in my opinion, I'll say so, and I'll ask for the baby to stay, and someone else can go out if that's possible, or if not, perhaps they don't need to do the other surgery that day. You know, that usually isn't what happens. You know, the nurses don't have the final decision in that. But if you don't think a patient's ready to leave, you've got to speak up about it.
Yeah, I'll tell you how to
Because the technology is here, the question of whether this technology ought to be provided for these patients has frequently in the past not really been addressed. But now when you're really talking about scarcity of resources, when you're talking about cutting down healthcare costs and Medicare reimbursement, et cetera, then you're really running into an area of scarcity of resources. And then the ethical problem of should we? Which patient should we? Is the question that's going to come up.
The principle of fidelity simply means that we should be faithful to our commitments.
I also called her family and told them that she was more serious and that she'd had some episodes this afternoon and that they might like to come in, and the son said that they were already coming in. Will you be coming soon to write anything? Do you want me to write it as a verbal order?
Mrs. Carter is semi-conscious and isn't able to communicate her own wishes. Although the whole healthcare team are convinced she is dying,
What about Narcan?
they have promised her family that they will try a final 10-day experimental treatment.
Is there anything you can tell me that'll make it more clear?
Mary is torn between her promise to the family and her commitment as a nurse to comfort her patient.
Yeah, she spontaneously comes back, but it makes me very nervous. We know that her situation is irreversible, and that it's even more certain now tonight after what's been happening, that she is really deteriorating and is not going to survive under any circumstances, I'm convinced. And yet I can't really sedate her at this time because of her instability. If it were decided that we would allow her to die, I mean, that support would be withdrawn, and essentially that means allowing her to go. Then we could give sedation, because keeping her pressure up wouldn't any longer be an issue. And it's during that time that it's real uncomfortable, I guess, for everyone, for the nurse especially, and of course the patient, because if your patient is suffering or in pain, you don't want that for them. You don't want their last moments to be uncomfortable. But until a decision's been made to let them die, then you are obligated to support them as best you can to keep their blood pressure up. And if that means withholding sedation, we do that here. I guess that's commonplace. That situation is just typical of what comes up, where you feel like you can't really comfort. And as a nurse, that's one of the things that you're taught you're going to do for people, and that's one of your roles, is to comfort people. And, not only to make them well, but also to try to make it as comfortable for them as possible. And there are times when you can't do that, and you feel like you've betrayed the patient. They've betrayed their trust, perhaps. You tell patients preoperatively, you'll be given medication for pain. And they believe you, and it is true, but it's not really true. You don't tell the patient what really could happen, which is that you might become unstable and hypotensive, and we might not be able to give you anything, and you might be in a lot of pain, and all I'll be able to do is talk to you and reassure you verbally. You would never tell somebody that. It would, that would, you can't. There's so much that people don't know. But at the same time, we have to honor our commitments to her family, too. I mean, it's their mother and wife that we're dealing with. The nurse is left holding the bag, I guess, so to speak. The nurse is at the bedside trying to support a patient who they know we're going to withdraw support on. So that's troubling, because I still want and have to do everything possible to support her. I am both obligated to and I want to because of the family at this point in time. I just want them to be, the promises that we've made to them to be kept.
Why don't I just stop and say, this is enough? And then, what good would my skills be to these people? Often, people leave here saying they got the best care, and we feel glad that we know they got the best care that they could have gotten. And that's a big reward for me as a nurse. And it's one reason I like to work here, because we can give really good care to our patients. You can't know that you're correct all the time in making these decisions. At least I can be here doing what I can within the limits of my power to make their death a little easier or the recovery a little more pleasant and a little speedier.
I don't usually have people asking me these questions while this is all going on. You can't be constantly examining, how do I feel about this? Or, you would be diverting your attention away from the job at hand. Afterwards, I might go home and think about it. I dream about things at night. I'm sure this happens to everyone, that it comes back to you. You try to not take things home with you. It's considered not healthy to do that a lot. So I try not to do that excessively. But sometimes things come back to me in my dreams.
It's not mine. Oh. Okay.
We've got a pacer, so that's
Yeah.
the pacer spike. What is the pacer? Those are the pacer spikes.
These are pacers. This is 70 Valium at the end of the case. It was relaxed with a total of 6 milligrams, and Paguan was not reversed. She received 3 units of whole blood, 400 cc's of lactated ringers, and her ACTs were, last ACT was 148. She received a total of 20,000 units of heparin, reversed with 400 milligrams of protamine. And that's about it. She did fine.